Assalamu alaikum wa rahmatullahi wa barakatuh. This is the third and last part in acid-base disturbance and ABG interpretation algorithm. I hope you have found the previous two parts convenient to understand and easy to memorize. I tried my best to simplify this knowledge. Actually, this knowledge is simple, but what makes it difficult is that there is different approach, multiple approach, but all the approaches we are trying to reach to the truth. The truth is what is the problem in this patient. Maybe some of scientists are reaching through touching the mouth, touching the tail, touching the leg, but we all have the same point, we all have the same question. We want to get the most possible information from the ABG. And here in this lecture, I try to put for you the easiest way, the most accurate. Of course, there is no any logarithm or algorithm for interpretation which is accurate 100%. All the algorithms you will find something stopping you or making you in doubt. But don't worry, because this is well known to all experts. But just try to fix in your brain the knowledge by specific methods so that you will not forget any step in the interpretation. We are doing interpretation for arterial blood gas, so it's very important, it's very vital to comment on oxygenation. Okay, so it is acid base and oxygenation. I want to remind you in the start that the acid-base disorders, what are these acid-base disorders? We have either metabolic disorder or respiratory disorder. The metabolic disorder usually compensated by the respiratory, and the metabolic disorder usually compensated by the metabolic. Okay, the respiratory compensation is fast, so that the metabolic problem we are telling it is compensated or non-compensated or partially compensated, while the respiratory problem, the metabolic compensation for the respiratory problem usually takes time, so that we have acute and chronic respiratory problems, either acidosis or alkalosis. Another point I want you to notice that during metabolic problem, usually the pH and carbon dioxide, they are moving in the same direction. While if the primary problem is respiratory, the pH and the HCO3 will be moving in opposite directions. As I told you, first of all, we will discuss the oxygenation. To comment on oxygenation in the ABG, you have two ways. First of them is to calculate the BF ratio, or the BaO2 divided by the FiO2. And here the normal is 400 to 500, while from 400 to 300, this is also can be considered normal, not pathological. It is just age-related changes. Less than 300, it's usually we start in the pathology. If accompanied by other criteria like chest X-ray, abnormal chest X-ray, and more hypoxemia on high FiO2 with beep, we can define it as ARDS mild or moderate or severe. The other method, this I leave it for ICU, to calculate the alveolar arterial oxygen gradient. From this way, we can differentiate the causes of hypoxemia. Either it is due to shunting or diffusion abnormality, or it is due to hypoventilation. Okay, how we calculate it? We will calculate first the alveolar oxygen tension, and then we subtract the BaO2 from the number which we have. Okay, but for the matter of ABG interpretation, for simplicity, if we are not considered to know what the cause of hypoxemia, it's enough to do the BF ratio. Now let's start our algorithm, the acid-base algorithm for interpretation. First of all, we will check the pH. If it is less than 7.4, the disorder here will be acidosis. If it is more than 7.4, the disorder will be alkalosis. Then we want to know what the primary lesion, if it is metabolic or it is respiratory. So we will check the relation between the pH and the BaCO2. If they are moving in the same direction, this will be metabolic problem. So the primary problem is metabolic. If they are moving in opposite direction, then the primary disorder is respiratory. So first step, check pH, then metabolic or respiratory, you will know the primary disorder. Then for diagnosis of mixed disorder, we have two steps. First of them is to calculate the anion gap. Calculating the anion gap, as we said in the previous part, it is sodium minus the HCO3 plus the chloride, the cation minus the anion. It is normal if it is 12 or less, no anion gap. At that time, there is no anion gap metabolic acidosis. If we calculate the anion gap and it was more than 12 milliequivalent, then we need to calculate the delta anion gap. What is the delta anion gap? It is the anion gap which you calculate and then subtract from it the normal anion gap, which is 12. Then we will calculate the corrected bicarb. Corrected bicarb is that number of the delta anion gap plus the bicarb of the patient. If the result is more than 24 by good number, by 2 or 3, in this situation we will say the patient have additional metabolic alkalosis. If it is less than 21, we will say the patient have additional non-anion gap metabolic acidosis. Okay? The second step is compensation. And for compensation, we will use the appropriateness rules. What are these rules? In metabolic disorder, and these two equations are the simplest one. Try to memorize them, they are easy, not difficult. So the expected carbon dioxide in case of metabolic acidosis, this is the famous equation which we all should know by heart, is Winter rule. It is 1.5 multiplied in the HCO3 plus 8 plus or minus 2. In case of metabolic alkalosis, the expected carbon dioxide, what should it be? It will increase, of course, but how much the increase? It will be the carbon dioxide will be 0.7 multiplied in the HCO3 plus 20 plus or minus 5. Now in metabolic alkalosis, you expect that the carbon dioxide will increase, so that you are adding 20, which is big number. Okay? Okay? You will find way to memorize this equation. But this is the easiest equation. Don't disturb yourself by different equations and different resources, different references. There is no problem. Just stick to one equation and try to memorize it. Try to find for you the easiest steps and fix it in your mind. Then you will not lose any information from the ABG. So as we said now, the compensation, this was for the metabolic. What for the respiratory? For the respiratory, we want to know if this disorder is acute or it is chronic. How we know this one? If it is acute, okay, the metabolic, the renal component or the metabolic component will not have time to compensate full compensation. So usually it will be moving, but moving a little number, smaller number than the chronic, than in the chronic problem. So in acute, you try to keep it in your mind. It is the rule of 1, 2, respiratory acidosis above, then respiratory alkalosis down, and in the chronic, also respiratory acidosis up and respiratory alkalosis down. Okay? So it is 1, 2, 4, 5. 1, 2, 4, 5. It's very easy. Just keep it in your mind. What this what these equations or what are these numbers? In respiratory acidosis, in acute condition, what you are waiting from the metabolic system, you are waiting for the HCO3 to increase. The HCO3 will increase for each 10 millimeter mercury increase in carbon dioxide will be increasing by 1 milliequivalent. In case of chronic, it will increase by 4 because there is time for compensation. In case of respiratory alkalosis, what you are waiting from the HCO3 to do, you are waiting it to decrease. So in acute situation, it will decrease by 2 for each 10 millimeter mercury of carbon of BaCO2. In the chronic, it will decrease by 5. So this is all the what we said. Oxygenation first, and then check for the pH. And to comment on oxygenation, we said the BF ratio. Then comment on the pH, Then check if it is metabolic or respiratory by the relation between the pH and carbon dioxide, BaCO2. Then, for diagnosis of mixed disorder, calculate the anion gap. If it is positive, calculate the delta gap and corrected Bicarb. From these, you will know if there is another metabolic problem. Then check for appropriateness to if in the metabolic disorder, to check if there is another respiratory disorder or no. Check the compensation. Okay, if the primary was respiratory, you want to know if it is acute or it is chronic by also this table and this number. It's easy, just look to it and keep it in your mind. Try to find this picture in your mind, fix it, you will not forget it. Okay, I want to remind you by very important information I told you before, that the for the normal ABG parameters, the pH normally it is 7.35 to 7.45, but we said the cut point for interpretation is 7.4. Above 7.4 we will consider alkalosis. Below 7.4 we will consider it acidosis. Then the HCO3, the cut point here is 24. Then the carbon dioxide, and the cut point is 40. Now we'll start cases. I'm reminding you every now and then by the same picture to keep it in your mind. We will follow the same steps. This is the first case. This is a 63-year-old man presented with generalized malaise. The ABG showed the pH 7.32, the BaCO2 is 24, the HCO3 is 12, the sodium is 137, the potassium is 5.4, chloride is 101, and BaO2 is 88. So what type of acid-base disturbance in this patient? What his oxygenation status? What is the primary disorder? And what about mixed lesion and compensation? Try to answer this question using the previous algorithm and then check for the answer. Okay, we are following the same algorithm. So the pH is 7.32, so this is acidosis. What the type? The pH is going down, the BaCO2 is going down, so they are moving in the same direction, so it is metabolic. What about oxygenation? If there is no mention about the FiO2 in the ABG, so that you consider the FiO2 is 21, which is room air. The BF ratio here is 400. Okay, normal BF. There is no hypoxemia in this patient. Then now we said acidosis. What we will do now, we will search for the mixed lesion. We will calculate the anion gap. If it is high, we will calculate the delta gap, and then delta anion gap. Then we will calculate the corrected Bicarb. Okay. I hope you have reached to the same numbers. Okay, so the anion gap here was 22. The delta anion gap is the difference between the calculated anion gap and the normal anion gap, which is 12. Okay, here it equals 10. We will take this 10, we will add it to the Bicarb of the patient, which is 12. It is 22. So 22 to 24, there is no problem. So this patient there is no additional non-anion gap metabolic acidosis. This patient have only high anion gap metabolic acidosis. Okay, because it is acidosis, now we will check for the expected carbon, and it is metabolic acidosis. We will check for the expected carbon dioxide by Winter formula. What Winter formula will say? 1.5 NHCO3 plus 8 plus or minus 2. Okay, so there is full compensation. Okay, now case number 2. Okay, the pH is 7.11, BaCO2 16, BaO2 is 90, on FiO2 50, HCO3 5, sodium 133, chloride 118, potassium 4. Okay, here I hope you reach to the same result. So this patient has simple non-anion gap metabolic acidosis. The history of this patient. The patient is 74-year-old, very anxious lady who presented with severe gastroenteritis, diarrhea. So diarrhea will lead to non-anion gap metabolic acidosis because we are losing the HCO3 from the diarrhea. Okay. Now this is case number 3. Here the pH is 6.88. The BaCO2 is 40. The BaO2 70. On FiO2 50. The HCO3 is 7 and the sodium 135, the chloride 118. Okay, so we'll follow the same step. First of all, the oxygenation. The BF here is 140. So this patient is hypoxemic. And actually, if accompanied by abnormal chest X-ray, accompanied by another criteria, we can consider this ARDS. Then, what type of the acid-base lesion? There is acidosis. What type? This acidosis, respiratory or metabolic? We said that we will check the pH and the carbon dioxide and the movement of them. Actually, here carbon dioxide did not move at all. So we will jump to the next component, which is the HCO3. It is 7. Clear that it is reduced, so the primary problem here is metabolic. We may have the two problems with equal power, but which one is affecting more the pH? We will know after we finish checking for the mixed disorder. Okay, now we want to find about the mixed disorder. We will calculate the anion gap. As we said, it is 10. So there is no high anion gap metabolic acidosis. Okay, there is normal anion gap metabolic acidosis or hypercholoremic metabolic acidosis. Then we will check for the compensation. The compensation here, it is acidosis. So we want to check, and it is metabolic. The HCO3 is 7. We will calculate the winter rule. The expected carbon dioxide is 16 to 20. So it's far less than the BaCO2, which is 40. So there is additional respiratory acidosis. So this patient have high anion gap, normal anion gap metabolic acidosis or hypercholoremic metabolic acidosis, and respiratory acidosis in addition to being hypoxic. So this is the conclusion. This is a combined non-anion gap metabolic acidosis and respiratory acidosis. Actually, this is the same patient described in case number 2, after she was sedated with benzodiazepine, which suppressed her respiratory center. This is case number 4. A 23-year-old man presented with generalized malaise and vomiting. The ABG showed the pH 7.38, BaCO2 40, BaO2 95 on room air, HCO3 23, and sodium 143, chloride 98. What type of acid-base disturbance this patient has? Okay, we will follow the same steps. First of all, there is a check for oxygenation. He is on room air, so the BF ratio is 400. What type of acid base? It is acidosis. What type of this acidosis? Here, the carbon dioxide is 41, the HCO3 is 23. What do you think? How you can judge? In this situation, where the BaCO2 is nearly normal, the HCO3 is nearly also normal, and the pH 7.387, the pH, there is no doubt about the pH. If it is less than 7.4, we will consider it acidosis. In this situation, it is better to wait to decide which is the primary lesion after you finish checking for the mixed disorder. So the mixed disorder, the steps to calculate the anion gap first, it is here 22. Then calculate the delta anion gap, it is 10. Then the corrected HCO3, it is 33. Then check for the compensation. From the compensation, it's 40 to 44. So there is no any respiratory component in this patient. Just there is metabolic. There is high anion gap metabolic acidosis, and as the corrected bicarb is 33, which is far more than the 24, so there is associated metabolic alkalosis. Okay, although this ABG looked normal, there is a combined disturbance in this patient. There is high anion gap metabolic acidosis and metabolic alkalosis. This patient was found to have blood sugar of 510 milligram per deciliter and ketones in urine. He had diabetic ketoacidosis responsible for his high anion gap metabolic acidosis and vomiting causing his metabolic alkalosis. Okay, this case number 5. Here this patient is a 58 years old man. He's heavy smoker, admitted to the ICU with sepsis. He's not intubated yet, but has NGT tube. His ABG showed the pH 6.88, the BaCO2 38, the BaO2 68, the HCO3 7, and the sodium 142, the chloride 100. Okay, let's comment on this ABG. The BF ratio is 340. 68 divided by 21%, so it is 340. The anion gap, sodium minus chloride plus HCO3, it is 35. The delta anion gap, it is 35 minus 12, so it is 23. Okay, then the corrected HCO3, 23 plus 7, so it is 30. So this patient having high anion gap metabolic acidosis and in the same time having, according to the corrected HCO3, it is far more than 24, so has additional metabolic alkalosis, and then we will check for the expected carbon dioxide. Expected carbon dioxide, because this is acidosis, we will calculate the HCO3 by Winter, the expected carbon dioxide by Winter formula. It is 1.5 in HCO3 plus 8 plus or minus 2. It is 16 to 20, so it is less than 38. So the patient having now triple lesion, having high anion gap metabolic acidosis, having metabolic alkalosis, and have also respiratory acidosis. Okay, so this patient have combined anion gap metabolic acidosis, metabolic alkalosis, and respiratory acidosis. Okay, and everything is explained in this patient, as you see. Now this is the last case. This patient is a 64-year-old with history of COPD, presents with worsening shortness of breathing and increased sputum production. The pH is 7.21, the BO2 60 on room air, the BCO2 is 50, the HCO3 26, the sodium 140, and the chloride 102. Follow the same steps also. Okay, according to oxygenation, the BF ratio is 300. Okay, so his borderline is good, actually, good oxygenation, accepted oxygenation. The acid-base status, the pH is acidosis. What type of acidosis? The pH and carbon dioxide, they are moving in opposite direction, so it is respiratory acidosis. Then calculate the anion gap. The anion gap here is 12, which is normal, so there is no anion gap metabolic acidosis. No need to calculate the other calculation related to the delta gap and corrected by Bicarb. Then now we want to know this respiratory problem acute or chronic. We will decide according to the change in HCO3. The HCO3, if this lesion is acute, will increase by 1 for every 10 millimeter mercury increase in carbon dioxide. If it is chronic, it will increase by 4 milli equivalent for every 10 millimeter mercury of carbon dioxide. Okay, so it is increased by, it's just BCO2 increased by 10, HCO3 increased from 24 by 2. We can say this is acute. Okay, this was the last case. I hope now you can use this algorithm easily and you memorize the steps. Okay, these are the reference which I used. Okay, thank you very much. See you later.